I think that idea that not all the niches are the same is really key. I mean, certainly as we look at the patients who've transformed from a myeloproliferative neoplasm to AML, there's that group of patients who the marrow themselves is really quite fibrotic. One's not even sure there's hematopoiesis going on in there, yet they'll have that 30% blast in the peripheral blood. And we think that the spleen can be an important harbor of those cells. And again, how well are drugs getting into that space? Are they really equally efficacious in that environment versus the marrow environment? A lot of opportunities. So as we think about particularly secondary AML, that I view as a huge area of our unmet need in this group of patients. They tend to be older. It's quite prevalent in that group. They tend to have, by pretty much any metric, they tend to have a more challenging prognosis in a lot of ways. Maybe Elias, as we think about both kind of pre-leukemic disorders, chronic myeloid disorders, MDS, MPNs, what are we learning about how they are different? Their path may be different than those with a de novo acute leukemia.
Well, Ruben, you're touching a point very important, because with population aging, we're seeing more and more of this damage caused the stem cell to more MDS happening. So I think if we're given an opportunity to live a lifetime, like eternally, we will all have MDS somehow. And then eventually we'll go into AML, but we will not be given this opportunity. So as you mentioned, there's two kinds of AML. The de novo one, which we have good results, decent results, but the secondary one are horrible. But we're discovering today the hidden life of cancer. So you have somebody coming with AML, but they had, even if they did not have an MDS, they had a certain period of time where they were acquiring something. And then they come to see you at the end where they have acute myeloid leukemias. This leukemia, they have very bad features, complex karyotype, multiple mutations, P53 mutation. We know they are very resistant to chemotherapy. We work on MDS, for example, and we reported some patients will never transform, or at least very late transformation, but some others do transform. And if we monitor these patients, for example, simply by doing a karyotype, we discover they can acquire certain abnormalities, and they go into acute myeloid leukemia. And I think it's similar as well in myeloproliferative neoplasm as well. We know, for example, in women who had breast cancer, who had adjuvant chemotherapy, some of them will go into MDS and AML, and some will never do. And then definitely there's some deficiency of some enzymatic repairs and others that can trigger these events and push for cancer. With the techniques available today to do sequencing to identify certain targets, maybe we can intervene earlier, stop this process, reverse it, or we may fail and we may think we're improving survival, but we survival only of patients from what we know. But hopefully we can intervene earlier and get to a place better than today.
I think that's a great point. You were mentioning pre-leukemic states, and they are the pre-leukemic states that we recognize and have a diagnosis and a name for, like MDS and MPNs. And we are beginning to understand better what mutations will lead to progression or are more likely to lead to progression. And that's helpful to help make decisions about patients. Does this patient require a transplant, or maybe they don't need one? And knowing which mutations are actually prognostic is helpful in that regard. But your other point is also valid, that many people who have what we call de novo AML don't have a recognized pre-existing condition. But if you were to actually sequence them at that earlier time point, you might find that these mutations are already present and already evolving without giving them a clinical phenotype. And I think that's an exciting new area that we haven't really explored, that maybe we can identify these patients who are at high risk, like patients who have had treatment for breast cancer and other disorders.
Rafael, you mentioned something very important. I had a patient coming to see me in the clinic last week. She's a nurse at MD Anderson. She had Hodgkin disease diagnosed, and she's going to get her treatment. Her concern coming to see us wasn't about her Hodgkin disease treatment. Her concern was, well, if I get Hodgkin disease treatment, will I acquire MDS down the road in 5-10 years? So now with the NGS and all these techniques and storing samples, maybe we can identify a group of patients at the baseline that have certain mutations that can evolve down the road. And therefore, that will take us to the personalized therapy, identifying a group of patients. Maybe they do not need adjuvant therapy, or they do something minimal or different intervention.
Yeah, so this brings us actually to the presentation by the Washington University group a couple of years at plenary session at ASH, where they tried to look at, what causes, or what triggers the development of secondary myeloid diseases, and obviously the first impression that you'll find more mutations or abnormalities in patients that had secondary MDS or AML, but that was not the case. So then they rethought of the hypothesis if there is probably pre-existing clone or pre-existing underlying abnormality that will increase the risk. So they developed this ultra-sensitive technique to look at minute clones of P53, and as a phenomenon of aging, we may acquire some minute clones of those, and it turns out that actually chemotherapy may eradicate the other cells, and what comes back as the recovery are those P53 mutant cells. They get subsequent hits, and how patients develop therapy-related MDS AML. So in the future, for this patient, maybe if there is like a technique where you can tell and you have an option of avoiding chemotherapy A or B, if this patient has a detectable P53 mutation in a small clone, maybe that's a patient we can avoid.
I think that's very, very relevant. In one of my roles is overseeing our cancer practice for Mayo Clinic in the Southwest. So I'm very mindful of our solid tumor colleagues as well. And again, there are situations where adjuvant therapies in various cancers, sometimes it's less clear how beneficial it will be, age is a factor, other components. So clearly, if you were concerned about a high likelihood of triggering a myeloid disorder, that'd be another important concern.